Good afternoon, everybody, and welcome to our next session of the APDR National Virtual Noon Conference Series. My name is Dr. Hart Beatty. I'm the chair of the APDR Education Committee and the Neuroradiology Fellowship Director at Boston Medical Center. Today, I'd like to welcome two amazing educators, and they're going to be speaking on cardiac imaging. A couple of just short housekeeping items as we go through every session. You all know that the lectures are being recorded, and questions and comments will also be recorded during the session. The recordings are being posted on the APDR YouTube channel, and the two previous sessions are up. It usually gives us about a week turnaround time to get the current lectures up. So we appreciate your patience on that. The attendees, your microphones are being muted. If you do have questions for the presenters, we ask that you use the question and answer tool in the Zoom platform. The chat tool will not be functioning during the session. With that, I'd like to introduce our two educators for today. First, Dr. Brian Ghoshhajra from MGH, Massachusetts General Hospital, Associate Professor of Radiology, and Service Chief of Cardiovascular Imaging. He's going to be speaking on coronary CTA for acute chest pain. And after Dr. Ghoshhajra, we have Dr. Stefan Zimmerman from Johns Hopkins, Associate Professor of Radiology. And Dr. Zimmerman will be speaking on CT and MR of cardiac masses. So without further ado, I'd like to start the session, and I'll stop sharing my screen. And Dr. Ghoshhajra, if you'd like to take over sharing yours.
All right, so a couple of disclosures. So I wanted to make this one interactive. So I wanted to encourage everybody to grab, probably the easiest thing is grab your smartphone and go to this web address, so polev.com/GHOSH, and that'll keep up with the presentation. So you'll see the menu choices come up. Or if you're a little more old school, you can go to just texting to this specific number. And if you don't, we'll still have all the answers, so you'll be able to see the responses. So go ahead and navigate to that address, and then we'll take a quick survey to start. So let's start out with what year of residency are you, just to make sure the system's working. So go ahead and log your responses. So again, polev.com/GHOSH. Okay, good. So working out well. Let me see how many responses. Good, we're racking them up fast. So we got a lot of radiology residents. We got a precocious intern somewhere in the around the world, and a couple of fellows and staff. All right. So welcome everybody. Okay, case one. So this is a 47-year-old man with new onset atypical chest pain. So my question to you is, looking at this image or this cine clip, what vessel is the most likely to be abnormal? So take a moment to kind of look at this image, study it, and we'll talk about what it is whenever we reveal the answers. Okay, and make up your mind about what you think is abnormal, and it is abnormal. Okay, so let's take that poll here. So what vessel is the most likely to be abnormal? Okay, so let's see how, there we go, okay. All right, so we got a lot of votes for the LAD, and then close second would be, or a second choice would be the right coronary artery. Okay, and so we'll go ahead and move to the reveal the answer. So this is a 47-year-old male with chest pain. He had a negative ECG and troponin, and he had and now known to have coronary disease. This is the CTA portion of the exam, and this is the right coronary artery. So it looks like a hockey stick, no big branches, got a couple small branches, and it's supplying the inferior wall. And you can see here that there is some plaque, and it doesn't look so hot in this C-view MIP image of the right coronary artery. And so what I was trying to show you with this image is that the inferior wall is a little hypokinetic. So obviously it's not akinetic, but it is thickening less than the anterior wall. If you look at this where my cursor is pointing the anterior wall, you can see it moves inward and it thickens by about 50%, Whereas if you now look at the inferior wall, and sometimes a trick is to cover up the top half of the heart and then the bottom half to really compare those, you can see it thickens a little less. So even if you didn't have the coronary anatomy, you might suspect that, like most people, this person is right dominant, and so he'd be supplied by the right coronary artery. So you'd look there for your stenosis. And this is just the little figure of the vascular territory. So the LAD usually supplies the anterior and septal walls, the circumflex, the lateral wall, and in most people that are right dominant, the right coronary artery supplies the inferior wall. Circumflex occasionally does supply the inferior wall in a minority of patients. And that's kind of basic knowledge that'll come in handy in a couple different cardiac modalities. So when you look here, this is showing you here that the spatial resolution of a CT is nowhere near that of a cath. The cath is much better able to see that, and this is a coronary cath here, this is a cannulation of the right coronary artery. You can see that hairline lumen. So it's patent, but really stenotic due to a plaque rupture. But the CT has better contrast resolution. It's showing me the calcified plaque, the non-calcified plaque that's causing this stenosis. So CT, better contrast resolution, gets more arrows here, but cath has better spatial resolution. All right, and here's the stenosis, and there it is with a stent propping it back open, and he did just fine. Okay, second patient, this is a 52-year-old ED patient with atypical chest pain, diaphoretic and nauseous at church. Later that evening, some chest pressure. Initial labs and ECG are again normal, so it's a good candidate for a CT. So the next question will be, what is this man's TIMI score? So what is TIMI? It's time is myocardium, and we're going to say, I'm going to highlight for you here all the abnormalities. So some risk factors in red and an aspirin use. Everything else he doesn't really meet for the TIMI criteria. So what is this man's TIMI criteria or TIMI score? And the point of this is not to make you memorize what comprises a TIMI score, but really just to think about what end of the spectrum you should be imaging. And good, we're getting a lot of ones, twos, and threes really. And so if you look closely at this, this TIMI score, you have to have at least 3 risk factors on this line to get even 1 point. So you have to have hypertension or treated hypertension. You have to be a smoker, have low HDL, not LDL, but HDL, diabetes, family history of premature coronary artery disease. So he doesn't even make the 3 risk factors that gives you 1 point on that line. And he did take aspirin use because I gave you that history. So, and he's not old enough, he doesn't have ST elevation. So he's on the low end, and the TIMI score is out of 7. So this is a relatively low risk patient. So somebody that's a good candidate for a CT. There's other scores, the heart score, there's a couple of, everyone's got a score out there, but the point is it should not be somebody that should go right to the cath lab. So just scrolling through some axial images here, I'm gonna focus you on this anterior oriented vessel and show you, you can see that in other vessels, there is some atherosclerotic calcifications. I'm going to reformat these source axial images into, you can see here is right dominant there, into a volume rendered image. And so there's the right coronary artery, here's the left, here's the circumflex kind of over here. And so this volume rendered image we know is not really a great way to look for stenosis, but more to orient ourselves. And so here is a vessel oriented in a curved planar reformatted view, and I'm showing you some plaque here. And so I'm going to ask you, what vessel is it, and what is the degree of stenosis? Okay, so what vessel do you think it is? Getting a lot of rapid responses, great. Okay. All right, so most people are voting a little more for the RCA, but also the LAD. And okay, so I'm going to show you again only a couple of circumflexes in the left main. Okay, so let's move on to the degree of stenosis. So regardless of what vessel you thought it was, what do you think the degree of stenosis is? And so I've given you a lot of choices here. Normally I would do it with free response to see kind of curiously what we get, because that's kind of the way that the caths are read, but we like multiple choice in radiology, don't we? And I think for good reason. Okay, I got a couple of 100 responses. Let's see where things are shaking out here. Oops. So that was, oh, there we go. Okay, so degree of stenosis. All right. So I like what I'm seeing here, moderate, maybe some severe, and it's hard to tell, right? We're an anatomic test. So I think I'd probably end up somewhere in there. I think I remember reading this case a few years ago, and it was a difficult, and I think I favored severe. Now, another way to classify that would be also to go by CAD-RADS, and severe on On the old definition would be the same as CAD-RADS 4, and moderate is CAD-RADS 3. So both are good ways to do it, but notice I didn't even give you choices of percent-wise. Like I'm not gonna call it a 37% stenosis because we know we're not that accurate. Okay, so we read this as left main. Here's the left main. And by the way, this is a vessel that does have a diagonal branch. And on the volume rendered, you could see it was anterior. So this is the LAD. And right at the first diagonal branch, you can see that there's a lot of plaque and it causes a severe stenosis. In fact, I can't even see any lumen, but I know my spatial resolution is not as good as a cath. So there's probably a couple of pixels of flow there. And so we thought there's some moderate stenosis here, but then it probably is severe right at the level of the D1 branch, first diagonal branch. And then we thought his function was fine. He had some calcium, a little bit of hepatic steatosis, and no other vessel diseases. So really he just has single vessel disease, kind of very tight. And so he's admitted to cardiology. The lab stayed normal, but he still went to cath, and here is the cath. So I'm showing you 3 views injecting the left main. And just to show you that he must be right dominant because I don't see the inferior wall supply. There's the circumflex. Here's the LAD coming around. And really the best view is centered right here. And you can see that tight, almost looks like an apple core. So this is what looks like a borderline severe stenosis. And the interventional cardiologist said, it looks about 75%. So they kind of chose something very accurate here. But they knew they weren't sure, so they did something called an FFR. So what does FFR stand for, and then what's positive? So let's go on to these questions here. So what is the definition of FFR? So go ahead and dial in your votes there. Let's see if I can show some responses. All right, good. Everyone's getting fractional flow reserve. That is the correct answer. And I did Google it. There is such a thing as a filtering face piece respirator, which is going to be probably much more useful knowledge for me this month. Okay, so fractional flow reserve. And let's go to the next question. So what defines a positive fractional flow reserve? So I gave you lots of choices here. So is it FFR less than 1, less than 0.9, all the way down to greater than 1, and all the way up to greater than 0.9? Okay, so go ahead and dial in, getting a lot of fast responders here. Okay, good. And these are the right answers here. So basically there's 2 right answers, and it's either 0.8 or 0.75. So fractional flow reserve is a flow wire put down your coronary, and they give intracoronary adenosine. And so if the ratio of pressure goes down, it doesn't drop at all, it's normal. So that means there's no stenosis. And if it drops by either 0.8 or 0.75, or drops to 0.8 or 0.75, then it's deemed to be physiologically significant. And why are 2 answers correct? Well, there was 2 big trials, and one used one threshold and one used the other. So either of these puts you on par with it being positive. So on this case, by the way, I think I showed you here the FFR was 0.67, which is positive. So that means this is the kind of patient that should get better with treatment because it's a significant stenosis, and he was stented. You can see here the vessel looks a lot better after putting a wire and a stent down. It's a DES is drug-eluting stent, PCI is percutaneous coronary intervention, and the important thing is medical management. He did great, asymptomatic a year later. Okay, next case here. This is a 51-year-old male with in the ED with chest pain. And I'm showing you here the non-contrast source images from the CT. So I don't see any calcium. And so my question to you is, if the Agatston calcium score is 0, what is the possibility of an ACS with a calcium score of 0? Okay, so let's go ahead and take that survey. Can we stop there? Can we just say, hey, I don't want to be here any later than you do, and we don't want to have to give contrast, we don't need to. Can we just stop with a calcium score of 0? Is it going to be a normal CTA? All right, so let's see our responses. Okay, and I like these responses. So the answer is you can still have an ACS or acute coronary syndrome with a calcium score of 0. Calcium scoring only applies if you are asymptomatic. So that's why we don't do them on symptomatic people. We can do it as part of a bigger study that includes contrast, but most of the literature gives you a number between 1 and 5%. So I would say 5% is probably the most correct based on the most number of papers published. But basically, If you're symptomatic, don't go with calcium only, all bets are off. And in fact, this is borne out even in stable patients by the CONFIRM registry. This is a small study of only 11-some thousand odd patients. Being sarcastic, it's a lot of patients, and you can see here that a normal CTA is the most common thing you see with a calcium score of 0, but you do have 50, even 70 and greater percent stenosis with a calcium score of 0 when you scan symptomatic patients. So the answer is you can definitely have acute coronary syndrome with a calcium score of 0. So here's the source CTA images. I remember reading this case and didn't really see anything. I didn't see any calcified plaques, so maybe I let my guard down a little, and not much here. And in fact, if you can find something, you're really good, or the zoom resolution is better than I thought, because I still don't see it to this day. But we looked at the short axis reformat, and you remember this is the anterior, lateral, inferior, and septal walls, and there was an anteroseptal hypoperfusion lesion, and there was hypokinesis of the anteroseptal wall here. So you can sort of see this, unlike the last case, or the first case that I showed you, where the right coronary artery territory was hypokinetic. Now the anteroseptal, or the LAD territory, is hypokinetic. These are a little noisy on purpose. We don't want to radiate people too much. And if you look here, that would correspond to the LAD territory. So let's go back and look at that LAD in MIP view. And wouldn't you know it, I could never really connect this this diagonal here, this large first diagonal, to the LAD proper. So there's left main, LAD. This is a MIP, so maximum intensity projection image, a little thickened, circumflex. And so this vessel is kind of discontinuous. And so the patient went on to an invasive cath, and there it is. So this is another depiction of a very high spatial resolution cath. And so the catheter is in the left main, it's zoomed in. You've got contrast opacifying the LAD and the circumflex. And that's something that's probably smaller than you can normally see with a CT, but the functional image kind of brought us back our sensitivity and made us look twice. So this patient was not a miss. You can also see all these fine vessels here, the small septal perforators. We don't see those with a normal CT resolution. So another example of why the function can help bring your sensitivity back. Okay, next case. This is case 4. This is a 52-year-old woman in the ED with an atypical chest pain. And her symptoms were strange. It was chronic nausea, and she was on some proton pump inhibitors. And she just came in, her son brought her in, and she said, "I'm just sick of feeling crappy." And her TIMI score was 0. She didn't meet a single one of the 7 points. Yeah, she was a smoker and some low HDL, but that doesn't qualify for a point. So really a low-risk patient, and let's see what the CT shows. So first thing I noticed is lots of calcium. And to be honest, I would never stop or discontinue a scan based on calcium score. We know that she could have totally patent arteries behind that calcium. But I do see that here's a vessel winking at me here. So that's the right coronary artery. It lives in the AV groove. There's the left anterior descending artery distally. So I saw some plaque there. I'm gonna let this play one more time. I'm going to scroll it back up, and these are thin source images, so they're a little difficult to fully interpret, but we always start with our assessment of the the axial images. Here's some OM branches, obtuse marginals. Here's look like some kind of a lesion in the circumflex, and then following this back up. So really a lot of disease here, and even all the way back up, circumflex, LAD. The left main has a lot of plaque. So let's reformat that and see what we can see. So here are all 3 vessels. So this looks like a hockey stick, no major branches. That's the right coronary artery. Looks pretty bad, huh? Here's the left main branching of the circumflex, and the left anterior descending, wrapping around the apex. Here's the circumflex, terminating as an obtuse marginal. So a lot of badness there. And then I also just gave you this image from the cine clip just to show you that the myocardium doesn't look quite right. So question 8, what therapy is indicated? So I gave you some acronyms. We'll go through what each of them mean, but go ahead and dial in your votes. Okay, let's see what the responses show. Okay, so it looks like everyone's favoring cabbage. So OMT is optimal medical therapy. Despite what you hear at presidential briefings, hydroxychloroquine is not a treatment for 3-vessel disease. Drug-eluting stents are not as good for 3-vessel disease because they actually don't have the patency, and this is by big research studies. So cabbage, coronary artery bypass grafting, that's the correct answer. TAVR is transcatheter aortic valve replacement, which is not really what I'm showing you here. I would need to show you aortic stenosis. And CABG plus AVR, it's possible, but I didn't really give you the aortic stenosis. And of course, all these folks get an echo to clear everything. And certainly this patient did. So this is 3-vessel disease, RCA occlusion, severe left main disease. You can see it's calcified and non-calcified. There's a second lesion in the LAD, and then a third one here. So you have moderate and severe disease. Circumflex had a moderate stenosis zone 2. So the disease in all 3 vessels or simply left main disease will buy you a coronary bypass graft. So the calcium score was high, but we didn't stop the scan. We saw some hypokinesis, and we also saw that the septum was very thick. So here's the cath, and there's that, looks like an apple core again. So really a tight left main lesion, a lot of myocardium at risk, and that left main lesion alone will buy you a CABG, and then you can see additional stenoses. The more you look, the more you see. Here's an OM stenosis. There's an RCA occlusion with collaterals going around the stenosis. So right to right collaterals, there's probably some left to right collaterals, things you may not see on a CT unless you know that there's a better resolution test coming. And then here is narrowing of the LV outflow tract. So this is somebody that with the CT was able to pick up severe hypertrophy. And so this person actually got a bypass graft, and they did something called a septal myectomy, where they carved some of that myocardium away to relieve the outflow. And she recovered uneventfully, and now she feels a lot less crappy. So even though that CT sounded like a low-risk patient, it was actually the highest risk patient, and that's why we image. Okay, case 5 is a 23-year-old man in the ED with chest pain. He's a non-English speaker. His translator said he started the chest pain about a week ago. His TIMI score is 0. He is young. He is not your classic patient, but we didn't know how to sort him out. His coronaries were normal. We know we can't assess coronaries by these volume rendered images, but they look pretty and they make nice presentations. But I put them up just to show you it's normal. You can take my word for it, but his ejection fraction was low. You can see here that the left ventricle, this is a short axis, this is a 4-chamber, this is a 2-chamber view, not moving so well. LVEF is 35%. It should be 50 to 55%, even in a young person. So he's got a low EF, and why could that be? So what's the most likely diagnosis in a young man like this with chest pain, maybe even has some high troponin? So let's survey the crowd here. All right, so I put in mirrors just to make it current here, but of course, I don't think Middle East respiratory syndrome is going on anymore, but good, myocarditis. So, and it could, it could be from a viral, COVID could do this even, but so Middle East respiratory syndrome is one form of viral infection, but not to my knowledge that affects the coronaries. ARVD is arrhythmogenic right ventricular dysplasia, and Hopkins is the hotbed for that, so I wouldn't lecture if Stefan Zimmerman's following me. Takotsubo syndrome, well, that's a stress cardiomyopathy, and then myocarditis. So that's infectious, usually viral, that diminishes your EF. And here's an MRI showing you subepicardial abnormal late gadolinium enhancement in the infralateral wall. Normal should be black, and here it is white. And so this is classic for infectious myocarditis. Okay. Last case, this is a 20-year-old man. He's in the ED and he has chest pain that started yesterday. And the real story is he had chest pain after weightlifting. He went to an outside hospital. 10 hours later, he had a negative PE study because, well, that's what outside hospitals do. He had a high troponin and he was transferred to our hospital, and our cardiologist said, let's rule out anomalous coronary artery. It's a great indication for a CT. We thought, okay, this is perfect. Maybe during the weightlifting, he pinched off an anomalous coronary artery. And here's his CTA. You can see not any calcified plaque to be had, but kind of a big looking RCA, and then it all of a sudden gets very small. Let's follow the RCA. Kind of highlighting it with a pointer here, and then wow, looks like a hairline lumen. And a 20-year-old should be about the last person that should get atherosclerotic plaque, though it can happen if you have a genetic disorder. And here you can see that we lose the RCA altogether. LV looks a little big. So and then no other abnormalities in the other coronary arteries. So let's reformat this. And I guess first, before we even go there, I've shown you no calcified atherosclerosis. I've shown you this really scary looking right coronary artery. So what's the diagnostic category we're in here? So I don't know if you remember, and here's that curved planar reformatted image. So short axis reformat at this level, here's another one at this level, and another one down here where I lose the vessel altogether. So I'm kind of highlighting where I could tell the vessels where it's expansile, kind of a crescentric shaped true lumen there. So what diagnostic category of disease are we in here? because I think we'd all agree this is not classic coronary atherosclerotic disease. Okay. All right, so we're thinking inflammation or infection or vascular. And the fact is, we're still dealing with, by the way, this is not congenital. This is not an anomalous coronary. Things came off the correct sinuses. So vascular is correct. The coronary is narrowed, but it's not atherosclerotic plaque. And you could argue that there is some inflammatory possibility here. But before we go on to tell you what it is, you can see here the inferior wall is hypokinetic, and it was an RCA lesion, so it fits. We're really driving that point home today. So right coronary artery territory, hypokinesis, and subendocardial perfusion defect if you have a dark enough room to view this in. Okay, here's his cardiac cath. So they went and did a cath because, well, that's what cardiologists usually do. And here's the right coronary artery cannulated. You have some irregularity, some kind of a thrombus in the vessel here, and then we lose the distal RCA altogether. He came back a week later after just medical management, and we got another cath because that's what we used to do. We don't anymore, but we see that the RCA is now patent, and here's the PDA and the PLV. So much more patent artery with just conservative management. And so, by the way, this is a spontaneous coronary artery dissection. So this is a tear in the vessel wall. It's just like an aortic dissection, but with smaller vessels. And there's an associated diagnosis. So what is the associated non-cardiac diagnosis? Go ahead and dial in here. So I have to confess, I had to Google how to spell Haller-Gordon-Spott's disease. I'm not a neuro guy, but it's apparently a neuro disease. Takotsubo syndrome, Dunning-Kruger syndrome, popular in the news these days, fibromuscular dysplasia, or factor V Leiden disease. And good, fibromuscular dysplasia. So factor V Leiden is a thrombotic disease. And so this is really an arterial process, and fibromuscular dysplasia happens frequently in people that get spontaneous coronary dissections. It's incidentally seen in 50% of the people with SCAD. So you might not be the person to diagnose the SCAD. That's often made in the cath lab, but you might be asked to look at the vessels to kind of solidify a diagnosis. Also associated with pregnancy, and in young men, it often is associated with drug use and steroids, and this guy had actually done both. So I think that was our last one. So just in summary, the teaching points we went through, and I think everyone got it. I saw a lot of very good correct answers. So teaching points. Number one, you need to know the coronary vessel territories. They're going to come in handy in many ways. CT has better contrast resolution, so you can see the plaque that causes stenosis. Invasive coronary angiography, ICA, has better spatial resolution. Number three, CCTA is the best for low to intermediate risk chest pain patients, which is everyone I showed you here, except for maybe the last case. And then multiplanar reformatted and curved planar reformatted images are the ones you should interpret. So we're not going to look at those volume rendered images. They're pretty, they're good for orientation, but we're not going to interpret stenosis there. The stenosis grading is imprecise. You should use broad categories, and CADRADS basically is the new way of doing that. Fractional flow reserve and or ischemic flow reserve, it's another kissing cousin, which is done in the cath lab, are the ways that to really sort out the functional significance once we see the lesions. And calcium score doesn't matter in symptomatic patients. I can't say that enough. It doesn't matter what your calcium score is. You haven't cleared the coronaries until you're done looking with a CT angiography. The myocardial function and perfusion can help when CT hits its spatial limits. If you see three vessel disease or left main disease, the best treatment is CABG. We also showed a case where the functional imaging being abnormal, or the cine clip, helped us find myocarditis, but the MRI was used to confirm. And finally, spontaneous coronary artery dissection is an increasingly recognized pathology, and it's associated with FMD. Thanks for your attention. I'm happy to take questions privately in the QA, and if you like bird websites, there's my handle. Thank you very much.
This is more of a dry talk, I guess I would say, but this topic seems to be a favorite topic of people who write tests that you guys have to take. So I think it's important stuff for you to know. So on we go. CT and MRI of cardiac masses. Just some disclosures first. As above, I acknowledge Jonathan Balcombe from the slides way back when, although I think I had to do some trimming of this talk to fit it into the 30-minute limit. So I think I deleted all his stuff, but nonetheless, I'll give him some credit anyways. So let's talk about cardiac masses. Overall, they're a very low frequency in autopsy. Less than 1% of the population has it, so they're a rare problem. The couple of facts that you should really remember: the majority of primary cardiac tumors are benign, so that's a good thing. Primary cardiac tumors are very rare, and really the more common cardiac tumor that you're going to see is metastatic involvement of the heart, which metastatic tumor, which is 40 times more prevalent than primary cardiac tumor. So those are the kind of key takeaway bullet points. When we do see a cardiac mass, a lot of times the question, and we'll get to this later, is this a real mass or is this thrombus? That seems to be the most typical question. And then more rarely, we know this is a mass. What kind of mass is it? The initial imaging method is going to be echocardiography, but that's limited, particularly depending on where the mass is. If it's a more posteriorly located mass, like an atrial mass, then it's going to have a hard time seeing and characterizing that mass. CT and MRI are both considered appropriate in terms of appropriateness criteria that are out there. One can perform either. CT is good because you can get really fine anatomic detail. So if you are looking at a known mass and want to know the association with the coronary arteries, I would say CT is great. It's also fast. MRI has the advantages of no radiation, as we know very well. And then it really gives you the tissue characterization. So the T1, the T2 information that can help you try and tease out what kind of mass you're dealing with. Speaking of MRI, what is the protocol that we typically use? Generally, we want to get, sort of like with any type of MR imaging, we want to get some T1 weighted imaging and we will get some T2 weighted imaging. The T1, we'd ideally like to get it with and without fat sat. So we can tell whether we're dealing with something that's a T1 bright fatty mass or a T1 bright mass due to some other intrinsic T1 bright characteristics such as melanin or blood. We're going to get some cines to see how the mass is moving. Is it like pedunculated and flopping around in the ventricle, or is it stuck? These images to the left that you see, those are images from a patient who has a breast cancer metastasis to the interventricular septum. Perfusion imaging, which kind of flashed over here, is nice. Good to perform so you can get some dynamic imaging of whether or not this mass is enhancing. And this is the case of, like I said, breast cancer metastasis. So you can see by the end of this perfusion imaging, you can see that there's some enhancement of the mass in the center of the ventricular septum. If you had a thrombus, for instance, you should see a filling defect that does not enhance. Late gadolinium enhancement imaging. We'll talk about this null time issue on the next slide. And then some optional things. T1 in and out of phase gray and echo can be used again for fat characterization if you think you might have a fatty mass, or MR angiography if maybe you have a gigantic mass and you're looking to figure out if it's involving the vessels. Sometimes that can be helpful as well. So just an aside about imaging masses with late gadolinium enhancement. So you guys might hear different terms thrown around to describe this sequence. There's delayed enhancement, there's myocardial delayed enhancement, late enhancement, or late GAD enhancement. Right now, the preferred term is late GAD enhancement, or LGE, in the literature. So that's what I'm using here. Using a long TI in combination with a standard myocardial nulling is really sort of standard practice now for evaluation of cardiac masses. What does that mean? Well, in your usual late GAD enhancement imaging, you're going to select an inversion time that allow you to perform, or that allow you to get nulling of the myocardium. So in this case, this is your standard myocardial nulling. So the technologist selected an inversion time that gives you dark, nulled normal myocardium. This patient has a big LAD territory infarct, so you can see some enhancement here along the subendocardium of the anterior wall and the apex. So that's nice normal myocardial nulling here, where the normal myocardium is dark. We also see that we have a mass that's dark, and so the question is often, is this mass thrombus or is it tumor? If we do a good job with our nulling, it is conceivable that one can have a tumor that's enhancing very similar to normal myocardium, and it is dark because we've nulled it very well. So how do we get around that problem where we could accidentally null away all the enhancement of our mass? We perform this long TI imaging. So in this case, we purposefully miss the appropriate TI time. We actually overshoot it a little bit, and we have a longer TI than normal, 600 milliseconds. What that does is it allows a little bit of time for the myocardium itself to recover signal. And so you end up with a gray myocardium here. This is normal myocardium of the inferior wall of the left ventricle, compared to this more appropriately nulled dark myocardium here. And if you have a tumor that is picking up GAD, then you'll see that that turns gray as well. In this case, you see that this thing remains dark relative to the normal myocardium. This is a thrombus then, right? So it's thrombus stays dark, normal myocardium gets brighter. So that's how we use these long TI images. Here's just an example of somebody who has the opposite going on. They don't have a thrombus, they have a metastasis. So you see in the normal myocardium, or normal nulling here, dark myocardium at the base of the LV, a pretty dark mass. You can already see there's some heterogeneous enhancement there, so you wouldn't really mistake it for clot. But nonetheless, it's dark here, and then as we go to a longer TI, it gets brighter, just like the normal myocardium does. So this is evidence that this mass is enhancing. So that's how that sequence is used. Okay, so let's just talk really quickly about thrombus because this is very important. It's the most common mimic of cardiac neoplasm, and we see it obviously low flow states, hypercoagulability, catheters, etc. Most commonly, you're going to see it in the left atrium or the left ventricle, and in particular in patients in AFib in the left atrial appendage, or in the LV if somebody has an old infarct with reduced function. Right atrial clot is common in people who have catheters. So look in the patient's history to see if they've had a chest port at some point in the past, and those carry a risk of systemic or pulmonary emboli. What about the imaging? Basically, you can look for calcification because they could calcify on CT. You usually do not have any enhancement, but occasionally on MRI, you may see a rim of enhancement, which is known as a fibrinous pseudocapsule. Basically, though, you should have a dark blob with maybe a little rim of enhancement around the edges. And then the other thing is, sometimes we'll talk about myxomas and how they're pedunculated and how they move around, but sometimes clot can do the same. So that's not always the best sign to tell whether you're dealing with a myxoma or a thrombus. Here's an example of left atrial appendage clot. This patient had clot in several areas, left atrial appendage here, and then the right ventricular apex here and here. And you just look for a filling defect, basically, in this case, kind of almost floating in the blood pool. This is a very common appearance for acute clot. This is a patient who has a catheter-related thrombus in the right atrium. You can see it flopping around on these cine images. On other images, we can actually see that the catheter attaches to the clot, so it's hanging off the bottom. So this is a pretty simple diagnosis here. And then this is another type of clot that we see, which is clot that's filling up an area of hypokinesis or akinesis in somebody who's had an old infarct. This is a late GAD enhancement image on the right-hand side, and you can see all this bright signal. That's actually transmural late enhancement due to a massive LAD territory infarct. And the dark signal here is all clot filling in that area. So huge clot. This is the perfusion imaging to show you that the clot doesn't enhance. So this is a common reason for somebody to have thrombus. Okay, so now moving on to primary cardiac tumors. This is a nice article from Radiology 2013, which lists all the incidents of cardiac tumors, and then the article goes through these tumors bit by bit. We're not going to go through all of them because we just don't have time. We're going to hit the highlights, but the big benign ones, myxoma, lipoma, papillary fibroblastoma, I think those are the ones you're going to see them most often, and at least in my relatively short career so far, those are the ones I've seen. The others, honestly, are the ones that you have to really go digging deep into your teaching file or ask around to find cases. Fibroma, rhabdomyoma. Rhabdomyoma, if you take care of kids, they're actually really common in kids with tuberous sclerosis. That's the one thing to know about those. But otherwise, certainly if you're an adult imager, you're not going to see them very often. And then in the malignant side, basically they're all sarcomas or lymphoma. That's the thing to remember. And the most common of the sarcomas is the angiosarcoma. Okay, benign cardiac tumors. Myxoma is really the important one to remember. So if you're thinking about things that you really encounter in clinical practice, the big things to think of are thrombus and myxoma. I'd say those are the two most common things you're going to come across. It's generally a polypoid intracavitary mass, often on a stalk, and patients can present either as the myxoma being found incidentally, like on an echo for some other reason, or because it gets really big and can cause obstructive symptoms. These are weird masses that can actually give you constitutional symptoms, what they call B symptoms, where you can get fever, anemia, weight loss, kind of the stuff you think about for people who have like TB or something like that, or lymphoma. And then the major concern with these guys is that they're going to put the patient at risk for embolic events. So left-sided tumors can serve as a nidus for some sort of thrombus formation, and then they can flick off and cause stroke. Most often they're going to be in the left atrium. That's 85%. The rest of them are usually in the right atrium. And interestingly, for whatever reason, right atrial myxomas can calcify. Left atrials never do, but right atrials do for some reason. And then rarely you can get them other places. I've seen either of the ventricles, biatrial, valve leaflets, and then Carney complex is the thing to remember. That's a multifocal myxomas. Okay, what are the imaging characteristics? The big thing to remember here is that myxomas are heterogeneous. They have all different tissue components. So they have some muscle components, they have some hematopoietic components, they have some myxomatous kind of fluidy components. So they're going to be really heterogeneous, and then they enhance. And the enhancement's heterogeneous, and the signal's heterogeneous. The other thing to think about is that roughly 2/3 of them are these kind of smooth, lobulated, usually round oval masses, and then there's 1/3 of them that have this villous appearance, almost like what you think of when you think of TCC in the bladder, this sort of frondy villous appearance. And we mentioned the calcification, and I talked about all these different heterogeneous components, and these lead to heterogeneous MRI signal characteristics. So here's a nice typical example of a myxoma. It's left atrial. It's arising from the region of the interatrial septum, which is the most common thing. Most common location for the myxoma. You can see in the upper left-hand image, which is a kind of a T2 weighted image. You can see that it's bright with some dark areas here. And then you see on this bright blood image, this is a cine image, again, bright with some heterogeneous low signal areas. And then on this late gadolinium enhancement, you have very bright centrally, which corresponds to some enhancement, and more darker, less enhancing areas peripherally. Very common appearance for myxoma. This is not clot, because you see that there's pretty distinct enhancement, and the heterogeneity isn't very typical for clot either. Here's an example of one of these frond-like versions of a myxoma. You can see the edges are really, basically just frond-like, right? They're just sort of pointy and irregular. I would say, they say in the literature this is about 1/3 of cases. I've only seen a handful myself, so I don't know if it really is 1/3. It seems like the smooth lobulated is much more common, but it does exist, and that shouldn't dissuade you from calling this a myxoma. Here's a more sort of classic example. This patient had breast cancer, and they found this mass on echo, and they were wondering, is this a metastasis or is this a primary myxoma? In this case, it was fairly easy diagnosis of a primary myxoma because it's mobile, it's coming off of the region of the interatrial septum, it has this heterogeneous appearance, it's fairly bright on the SSFP images, which are heavily sort of T2 weighted with a little bit of T1. So you can see bright and heterogeneous on those SSFP images. It prolapses through the mitral valve, which you see here on cine, which is where it's moving into the left ventricular cavity. That's typical for myxoma. That's something that's been reported as a way to distinguish myxoma from thrombus. And then you can see on the on these late GAD enhancement images, there's some central enhancement. So very typical myxoma. This is one of those ones that has that sort of smooth, lobulated contour, and the very classic location arising from the interatrial septum. All right, so moving on from myxoma to lipoma. Lipoma is the second most common benign cardiac tumor, and usually these are going to be asymptomatic and just found incidentally by some other type of imaging. There are reports of them causing arrhythmias or compression symptoms, but to be honest, I've never really actually seen it. And the one association you should have in your mind is increased frequency in patients with tuberous sclerosis. So there's two things now I've mentioned. Two types of cardiac masses you should have it linked in your mind to tuberous sclerosis. The first one was the rhabdomyomas. So patients with tuberous sclerosis when they're infants, it's very common for them to have rhabdomyomas, which are basically cardiac masses made out of a tumor of the cardiac muscle. And interestingly, they tend to regress on their own. So sometimes they don't have to be treated, they can just be followed. So that's one thing with tuberous sclerosis. And then the other thing is that they get lipomas. So those are two important things to remember. What is a lipoma? The way you define a lipoma is that it's encapsulated. And this is a distinction from lipomatous hypertrophy of the interatrial septum, which we're going to talk about. And basically, imaging-wise, the signal characteristics are those of fat, right? High T1, and it's going to drop out on fat-sat images. So here's a nice example of intramyocardial lipoma. these are super rare. I've only seen 1 or 2 cases that look like this, where you have a big blob of fat within the myocardium itself. You know, maybe this patient did have an arrhythmia. It seemed like that would make sense. There's conductive tissue that lives in that septum. Honestly, I'm not sure, but nonetheless, benign thing, leave alone lesion, right? Here's an interesting one. This patient did have tuberous sclerosis, and this is a little tough to see, but there's a mass here. There's too much stuff here in the apex of the left ventricle. And if you look closely, there's this dark rim around this mass, which is bright in the middle. It's kind of like a triangular shape. And that dark rim, it turns out, is actually India ink or etching artifact that you see at the interface between fat and, in this case, blood pool. Just like this little black line that we see at the interface between skeletal muscle of the chest wall and the fat of the subcutaneous fat. You know, and the things that we think about, you know, this type of India ink artifact is the, you know, chemical shift of the second kind. So you can actually see that on these SSFP images, which can be helpful. So here's more imaging of that same mass. Bright on the T1 weighted images here and here. So that suggests it's fat. And then when we do T1 with fat sat, boom, it loses signal. So certainly this is going to be a fatty mass. And with the history of tuberous sclerosis, it's kind of a no-brainer. This is a lipoma. And then you can see lipomas in the pericardium too. So here's 2 different patients with 2 different types of pericardial lipomas. Here's one over the posterior wall on the left atrium, and here's one more centered on the left AV groove region. You know, again, benign leave alone lesions. One note about lipomatous hypertrophy of the intraatrial septum. This is important to know because you need to distinguish it from a lipoma. It's fatty infiltration of this interatrial septum region here, and you get the typical dumbbell shape. And why is that? Because you have an area in the middle here, which is the fossa ovalis, which does not have any fat cells, so that's spared, and then you get the blobs of fat on either side. And so some people think that looks kind of like a dumbbell. I mean, in this case, obviously an asymmetric dumbbell, but nonetheless, that's the dumbbell shape that's talked about. It follows all fat on all sequences. It's not encapsulated. In this case, it's just like normal fatty fat cells in that region, which just get bigger. And so no capsule. And then the other interesting thing to note is that these sometimes can be picked up on echo, and sometimes people say, oh, is that a mass? And then sometimes they'll maybe end up in a PET scanner, and then they'll be bright, and then, you know, people get really worried about it. It's important to know that fat in the intraatrial septum can show up as bright on PET because there's brown fat in there. Brown fat can take up FVG. It doesn't necessarily have to be a lipomatous hypertrophy situation. It could just be, you know, normal size fat in the intraatrial septum, but it can be bright on PET, so just something to be aware of. Okay, one more benign mass that I'm going to show you guys before we move on to the malignant ones. That's papillary fibroblasoma. This is an interesting little mass. It's usually very small. 99% of them are less than 2 centimeters. So a tiny little mass, and it's a little mass that lives on the valve. It's usually on the atrial and the aortic side of the valve. This is in distinction to a vegetation. Vegetations are usually on the ventricular sides of the valves. And it has a thin stalk, it's mobile, it's generally non-enhancing. And MRI, I wrote here low signal on all sequences due to fibrous tissue. Honestly, sometimes because of these, it has some myxomatous parts to it, just like a myxoma. It can actually have some bright signal on T2. So let's see, here's an example. This is probably one of the best examples I've ever seen of this thing, where it's this blob that's attached actually to the aortic valve. Let me see if I can get this other one to move again. Okay, and there you can see there's the valve leaflet here. It's a stalk, and it's a sort of frond-like mass arising from the valve here and here. And this is what they look like. This is a pretty big one as they come. Oftentimes they're smaller, but they'll come to imaging, and honestly, I think usually the diagnosis can be made by echo, but every once in a while they'll come to imaging. Maybe you'll see a little bit of enhancement. But based just on location and the fact that this patient doesn't have any risk factors for vegetation, you can basically call it a papillary fibroblastoma. Here's what it looks like on MRI, low signal here on the SSFP images, and then a little bit of bright signal on the more T2 weighted images here. And this is this gelatinous appearance, some sort of frond-like edges, and then a lot of water content. I think I had noted before, it's been called a sea anemone appearance. So I don't know if you've ever seen one of those. I guess they look kind of like this. All right, moving on. So we finished up the our tour of benign cardiac tumors and hit the most common ones. We left out the fibromas, the rhabdomyomas, things like that, but those are generally big masses that follow signal of myocardium because they're made from smooth muscle, or excuse me, from muscle cells, and oftentimes they're more frequently found in kids. Malignant cardiac tumors, the main things you need to worry about, or the main thing you're going to find in primary malignancies of the heart, is sarcomas. And the biggest one of those is going to be angiosarcoma. And then there are other types. This is from the literature. Undifferentiated sarcoma, malignant fibrous histiocytoma ossea. I've never seen one of those. Leiomyosarcoma, osteosarcoma. Yeah, believe it or not, you can have an osteosarcoma primary from the heart. For some reason, I guess sometimes bone cells get lost in cardiac tissue and form tumors. It does happen, although very, very rare. The interesting thing about sarcomas, and unfortunate thing, is that they actually tend to affect slightly younger patients when we think about the cancer population, mean age of 41. So you think about like 30-some-year-olds, 40-year-olds. And oftentimes they present with hemorrhagic pericardial effusions and tamponades. So they're these patients that come in sick, and you do a chest x-ray and see a big pericardial effusion. They do an echo. It looks like a really complex exudative effusion. And then further workup reveals blood, and then, tumor, et cetera, et cetera. The important thing to know about angiosarcoma is that it usually involves the right heart, and in particular the right atrium. So that's the thing you should have in your head. Aggressive mass, right atrium. That's the key thing for angiosarcoma. The other sarcomas can really be anywhere. The literature will tell you left atrium. They're so rare, honestly, I don't know that you can make many rules for them. The big thing you want to think about, though, hemorrhagic pericardial effusion and just an aggressive invasive mass often invades fat planes and surrounds and/or narrows coronary arteries. And you'll think about metastases and lymphoma because those are other types of aggressive masses. So here's an angiosarcoma, both the CT imaging and the PET. And what we're seeing on the PET, it kind of nicely points out where the abnormality is on CT, this bright FDG uptake along the right atrial wall. This is really kind of classic, this thickening of the right atrial wall and lots of irregular, very, very bright enhancement. I mean, if you look, it's almost the same as the blood pool, right? So these things are really, really, really avidly enhanced, and they can show up super bright, sometimes so much so that, if you have kind of streak artifact here, maybe you'll chalk it up to some streak artifact in the right atrium, may actually go unnoticed. And I've seen that before, where the tumor, because it enhances so avidly, you don't even realize it's there because you chalk it up to motion blurring or streak artifact. Here's that same case on multiple MR images. You can see here's some heterogeneous bright signal on the T1 weighted image, and on the SSP images, you've got a mix of high and low signal areas, probably some necrosis in some regions, and then some very, very bright enhancement here on the perfusion images. So I'll just go back real quick. So the main thing to think about, angiosarcoma, aggressive mass, right atrium, and avid enhancement. Those are kind of the big things to think about. Other masses, so this is an example of a leiomyosarcoma. There's nothing really specific about this to say it's a leiomyosarcoma. It just looks like an aggressive mass on the left side of the heart. Primary aggressive masses generally are going to be sarcomas, or the other possibility is lymphoma. Sarcoma is a little more common. So this ended up being a leiomyosarcoma. Here's just some more imaging of that same mass. You can see it's really big and aggressive, involving the left ventricle, displacing the coronary arteries, extending into the LV cavity. So a big, nasty mass, you think sarcoma. Last type of, or second to last type of mass we're going to talk about, lymphoma. Primary cardiac lymphoma, very rare, although more common in HIV/AIDS or transplant patients. Only 1% of primary cardiac tumors. So we know primary cardiac tumors in general are very rare. And then, so this is a rare version of a rare thing. So you don't see this very often at all. But the presentation, dyspnea, chest pain, arrhythmias, and often tamponade because you get pericardial involvement. And basically lymphoma, cardiac lymphoma, nothing too special about it. It just looks like a very aggressive, nasty mass, may have pericardial involvement, and can involve, often encases the coronaries, but doesn't obstruct the coronaries. And honestly, the more common type of lymphoma you're going to see is secondary involvement of the heart. You can see that more common when somebody's got lymphoma elsewhere, and you get this very aggressive secondary involvement of the heart. The differential metastases in sarcoma, obviously. So here's a case This patient, honestly, we thought it was primary cardiac lymphoma when we first diagnosed it, because this was the presentation he presented with, I can't remember, some sort of arrhythmia or chest pain, and the echo eventually found this big, nasty, aggressive mass centered between the left atrium and the right atrium, and invading both the right and the left atrial cavities. You can see there's some enhancement here on the post-contrast imaging. On the CT image, you can see some central necrosis and some enhancement, but it turned out the guy actually had lymphoma in his bowel as well. Probably the primary down here in the terminal ileum. Remember, you think about lymphoma in the bowel, you think about it sort of an expanded bowel lumen, and he had that exact thing going on. It was a very irregular mass with a big dilated lumen. This was in the terminal ileum. So secondary lymphoma of the heart, usually something that looks very aggressive and nasty. Okay, last thing, metastatic tumors. These are 20 to 40 times more frequent than primary tumors. And of the types of metastatic tumors you're going to see, lung cancer, lymphoma, I don't know why leukemia is on this list, honestly. I don't know what that's from. Forget about that. Breast cancer and esophageal cancer are those listed as the most common. You can get involvement of the pericardium or the myocardium, and because of those things, you can end up with tamponade or coronary invasion. These metastases can take different routes, right? So one that we think about is the venous extension, so crawling up the inferior vena cava. For that, you think renal cell, you think hepatocellular carcinoma, and you think about adrenal cortical carcinoma, right? Then hematogenous Mets. Hematogenous Mets can go to really anywhere in the heart. They can go to the pericardium, they can go to the ventricles, they can go, in this case, you can see to the interatrial septum. So there really are no rules. I would say most commonly they're going to end up in the ventricles. Here's an example here of multiple multiple ventricular and interatrial Mets in somebody who had an islet cell tumor. Here's melanoma. The one thing you want to think about for melanoma, as you do always with melanoma, is that can be T1 bright on MRI. So you need to have those or fat side images and non-fat side images to make sure that this is not a lipoma. And then the other type of cardiac mass, you have hematogenous, you have growing up from the IVC, and then you can have growing in from the lung. And this is an example of somebody with a big cancer, lung cancer, growing into the pulmonary vein and invading the left atrium. So you see that not uncommonly as well. And then just one more example, a really massive, nasty met. I would say when we see ugly metastatic disease to the heart, usually melanoma is one of the primary ones you think about because it can be so aggressive. This patient had a really terrible RV met from melanoma. So just to sum up, cardiac masses are rare and metastases are much more common. So that's one thing to always remember. Myxoma, most common primary tumor, and it is benign. And the features that you look for are heterogeneity and enhancement. Sarcomas, most common primary malignant tumors, usually angiosarcoma. For those things, for the angiosarc, you're gonna think right atrial wall, you're gonna think really brisk enhancement. You'll think about people who present with bloody pericardial effusions. And then metastatic disease is 40 times more common than primary cardiac tumors. And I believe that is it.